one and all. Well, the first session of the lecture series conducted in association with DAMS MedMeet International Undergraduate Conference hosted by College Union 2020 of Government Medical College, Calicut. Myself, I'm Tanya Nasser, final year MBBS student from Government Medical College, Kozhikode. As Hippocrates, the father of modern medicine, rightly quoted, wherever the art of medicine is loved, there is also love for humanity. Today, we have with us one of the most respected faculties from the Department of Medicine, Government Medical College. I would like to invite Dr. DANISH, Assistant Professor, Department of General Medicine, Government Medical College, Kozhikode, to the session. In the next 2 hours, Sir will be enlightening us with different case scenarios, its symptomatologies, and everything towards it. Our teachers have always stood as a strong pillar of engagement for all our activities held in the. So, without further delay, I would like to hand over the session to Dr. Danish, sir. Over to you, sir. Thank you.
Thank you, Tanya. Okay, good evening, one and all. So today's session, the session is on the symptomatology analysis in a clinical scenario. So hope you all know the history analysis is the cornerstone in making a clinical diagnosis in medicine. So the art of history, you have to learn the art of history, and only after mastering the art of history, you will be able to become a good clinician. So you might have heard so many instances where the history was the most important reliable thing for making a diagnosis. So to share, there are so many incidents, but I would like to share one story, and after that we will move on to the subject proper. So when nearly 1 year ago, while I was on casualty duty, one of our senior residents showed me a case that a person, nearly 54-year-old male, who got admitted to the casualty with a history of probable stroke or hypertensive encephalopathy, and the person was intubated and he was sick. So after seeing that patient, since she told me the diagnosis like that, an MRI was immediately planned and took an MRI. And I saw the patient after 2 to 3 hours nearly. So by that time, the patient was, the general condition of the person was, the general condition of the patient was deteriorating and the MRI was normal. So again, analyzing the person was in that stage, and his vitals were otherwise stable, only the BP was a little bit high and the oxygen saturation. So a decision to remove the ET tube, that means the endotracheal tube, was made, and after removing the tube, since the MRI was normal, they removed the tube, and on seeing that patient after a few minutes after removing the tube, he was completely sinking and he became sinused, and again the person got reintubated. So at that time, the diagnostic dilemma was there. What could be the problem? So again, I took the history. So at that point of time, his wife was there. So the history was like that, no? This person had gone for a travel to Bangalore, and he had a paddy field over there, and he, along with his 2 friends, stayed over there. And nearly at around 2 a.m., he returned back to his place near Nilambur in okay. And in that, on the travel itself, he started developing recurrent episodes of nausea and vomiting. And after that, this person had increasing sweating and all, and he shot to a nearby hospital. And in that hospital, this person was detected to have high blood pressure, and he became drowsy. And at that time, he got intubated. This was the history which I got. So while again observing the patient and conducting all these scenarios, the person's only problem was the person was having difficulty in breathing. Only the respiratory problem was there. All the parameters was normal. So what could be the reason? Tanya, any guess which you can make out with that history? Anyone? Tanisha, any idea what maybe you think of this? What it could be only a respiratory problem? And no, when I again examined him, the striking finding I got was bilateral ptosis. Now you might be able to pick up the diagnosis, no? It could be. It could be a straight bite, no? Because he is having bilateral ptosis and respiratory paralysis, and he became drowsy, and he had a visit to his farmhouse. And at that time, his wife was not aware of any of this scenario, and his friend came and he told that they killed one of the snake, yes, on the previous day in the nearby room. So we gave ASP and the person completely recovered and he returned back to his home. So a detailed history taking is a must in each and every clinical scenario when you are having some doubt in making a final impression. So the history is again the cornerstone in making the clinical diagnosis. So analyzing each and every symptom of the person is very important, and only then we will be able to make out a final diagnosis. So each system has got its own symptomatology, and the final diagnosis usually relies on with the history and clinical finding. Okay, so the history has got a major role in analyzing symptomatology, especially in neurology. So here today we will be discussing on neurological symptomatology of a clinical scenario, and one of our students will be presenting the case to you, and we'll listen to that, and after that we will analyze the symptomatology. Okay, so Miran, can you present the case?
Yes, sir. Good evening, respected DANISH sir and fellow viewers. I'll be presenting the case. Presenting the case of Mrs. Kalyani Sukumaran. She's a 50-year-old lady coming from Calicut. She's a homemaker, and history is taken from the patient and her husband, since she's having some speaking difficulty. The presenting complaints are as follows: unsteadiness while walking, difficulty in swallowing, and hoarseness of voice, numbness and paresthesia over the left side body, and difficulty to perceive sensation over the right side of the face. She had these difficulties for the past 3 days. Now, coming to the history of the present illness, Mrs. Kalyani was performing her normal daily routine as a homemaker 3 days ago. While she was engaged in some heavy domestic work using her right hand, she developed neck pain and sudden onset of headache, nausea, vomiting, along with vertigo. She called for help and took rest for some time. Her symptoms progressed in the next few hours and realized that on attempted walking, she lost balance and was not able to walk properly, even though she was able to catch one of her chappals and take proper steps. The cadence and the sequencing of the right-sided limb movement was most effective compared to the other side. Moreover, she had difficulty in reaching out for an object. Either she may underreach or overreach. She also had tendency to fall towards the right side. There is no history of any head tremor or ataxia while sitting. When she was given a glass of water to drink, she had difficulty to swallow the water, and she could realize that her speech was slurred. She was able to comprehend and communicate properly, but the speech she uttered was slurred, especially certain words like ga, ka, and na. There was some amount of hoarseness of voice associated with it. She also added that when her face was washed with hot water, she was unable to appreciate the sensation over right side of her face, and she was having a feeling of burning paresthesia over that region. It is because of these symptoms she was taken to the Medical College Hospital, Calicut, and was hospitalized. Emergency CT scan was taken and bile tube was put. The next day, her husband noticed drooping of her right eyelid and narrowing of the palpebral fissure. She was well able to close her eyelid, and there is no double vision associated with it. She was also having burning paresthesia over right side of the body of the face, which became more intense, and the headache and vertigo got somewhat relieved. There is no history of altered sensorium, seizures, difficulty in opening her mouth, facial deviation, tinnitus, hearing loss, weakness over left side of the body, or any involuntary movement. There is no history of symptoms of angina, palpitation, cough, dyspnea, jaundice, bleeding manifestation, arthralgia, or any fever. That's the end of the history.
Okay, that's a well-rounded history, Biran. Thank you. So you heard the history. No? So to summarize, a 34-year-old lady was a homemaker who suddenly developed a history of headache, nausea, vomiting, and vertigo. followed by unsteadiness while walking. And she had history of difficulty in swallowing and slurring of speech. Along with that, she also felt some numbness and burning paresthesias over the right side of the face and the left side of the whole body. And the next day, the patient had some drooping of eyelid on the right side. So, with this history, this is the nutshell of the summary of the history that he told. So, how do we analyze these symptomatology? How do we make out a clinical diagnosis based on these symptoms? Okay, so for that, in each scenarios in medicine, you have to find out which system is diseased. The next question is what is the anatomical localization of the disease or why the symptoms are occurring due to which anatomical structure is producing all these symptoms. Second, what is the type of disease or what is the pathology over there? Then you should think of what etiology it could be. Then you have to think of what functional status. Okay, so this is how we analyze symptomatology in each system. In neurology, again, we have got a similar pattern, but in that we add two more things. So, in neurology, we have got a certain form of localization. So, for that, now I am going to present my screen to you and we'll discuss on that. Okay, Tanya, okay, is it fine? Can you follow?
Hello, yes, sir. Hello.
Okay, yeah. Okay, so hope you can hear. So now, when you analyze the symptomatology in neurology, the first, we have told you the system localization. So here, which system do you think the person is having a disease? The system here, the cardinal symptom of this person is pertaining to nervous system. So this person is having a disease which is originating from a nervous system. Okay, now what is the in neurology? You have got one more adding to this. The next question is what is the type of neurological disease? See, you told it is a neurological disease based on the cardinal symptoms of the person, like what unsteadiness while walking, difficulty in swallowing and slurring of speech, and sensory symptoms. So all these symptoms are pertaining to neurology. So what type of a disease? What type of a disease do you think, Asmin? What type of a disease is this patient having?
Some ataxic hemiparesis.
Okay, so the type of disease is she told it is a ataxic hemiparesis. That means, what type of a disease is it? It's a sudden onset of a focal neurological deficit. So all of a sudden, this lady was absolutely normal, but all of a sudden, this lady developed all these symptoms over a period of hours, to 1 or 2 days. So that means sudden onset of symptoms of a, so it's called as a stroke, or we call it as cerebrovascular accident. So the type of disease here is cerebrovascular accident because acute onset of a focal neurological deficit attributable to a vascular cause. Okay, so that is called as a stroke. So in that, the second addition, so this is the first localization here. The second point is what is the topography of representation? So what is the topography? See, so what is the topography here? This patient is the, so the topography means, you might have heard of hemiplegia, paraplegia, ataxia, cranial nerve syndromes, like that. So the topography that is presented over here is unsteadiness while walking. So the topography here is ataxia. Is it a pure ataxia? No, it is an ataxic syndrome. So it is an ataxia plus it is an ataxic syndrome, or it is an ataxia plus other cranial nerve or long tract symptomatologies. Okay, so it is an ataxic disorder. So it is an acute ataxic disorder. So this person is having an acute ataxic disorder. So the third aim of here, the first localization is system, that we localized it in our system. So under this, the type of a disease is what we call it as. So we got that it is a cerebrovascular accident in the form of an ataxic disorder of acute origin. Okay, and now we move on to the anatomical localization. And after that anatomical localization, we will discuss on what pathology is there in that anatomical localization. Okay, so for that anatomical localization, we have to analyze the symptomatology of each of these symptoms in detail. Okay. Am I fast or slow? Is it okay?
Okay,
Yes,
sir.
sir.
Okay, thank you. So the first symptom here is vertigo. Okay, now I will write now here vertigo. Second symptom is unsteadiness. Third symptom is sensory symptoms over the face. Okay, the next is dysarthria and dysphagia. Okay, then the person is having drooping of eyelid. Okay, so these are the symptoms that now we will analyze what this person had a feeling of vertigo. That means the feeling of impending loss of what this person had a feeling of what rotation of his body. Okay, so this person had a feeling of vertigo. So Viran, was it actually a vertigo, or did you ask very specifically, was it a dizziness, was it a vertigo, was it a pre-syncope? Because such a differentiation is very important in neurology, because each of this, the meaning of each of these terminologies, are very, it's different, because distance is other
Hello.
or please, hello.
Sorry to interrupt, but I think the
Okay.
small issue in audio is getting interrupted. So
Okay.
in case if any electrical devices like fan something is working, could you please lower it?
Yeah. 1 minute.
Okay, sir. Thank you.
Is it okay now? I was asking that initially also. Is there any disturbance? So is it clear now?
Yes, sir. It's clear now.
Okay,
Thank you, sir.
do you want me to again talk on the other aspects which I told? Was it highly unclear, or do you want me to repeat again, or should I proceed?
So you can proceed now.
Okay, fine. So we were discussing on approach to vertigo. Okay, so the vertigo could be either, it may be like a phenomenon like, so you should distinguish whether it's a pre-syncope. That means the person had an impending loss of consciousness. Okay, it's a pre-syncope. Whether he had a feeling that he may lose his consciousness or lightheadedness, or was it a symptom like, or is it actually dizziness, or is it a lightheadedness? Okay, so it's different from vertigo. Okay, if it is a vertigo, if it's an actual vertigo, it should be either a central vertigo or a peripheral vertigo. So what do you think? Is it a peripheral vertigo or a central vertigo in this patient? Which one will be done?
Most probably a central vertigo, sir.
Okay, what are the points with which you can say it could be a central or is it a peripheral like that?
Peripheral vertigo is more commonly associated with tinnitus and hearing loss, and it is
Okay,
not present in this case. Then
oh, very
central
good.
vertigo is associated with long track symptoms, which is present in this case.
Okay, fine. Okay, good. So the peripheral vertigo is usually more symptomatic. The person will be severely symptomatic. He will have vertigo in each and every position, and he will be having nausea and vomiting. And so, okay, it may be associated with hearing loss, or it may be associated with tinnitus. But in central vertigo, the symptoms are more or less what less symptoms, and it is associated usually with other cranial nerve symptoms or long tract symptoms. So, if a person is having vertigo, along with that he is having dysphagia, dysarthria, ataxia, or he is having any sensory symptoms of a long tract, that means a spinothalamic tract, anything like that, you go for a central vertigo. If it is a more symptoms, severe symptoms with hearing loss, tinnitus and all, it is more of a peripheral. So here all the points are favoring a vertigo of what? Central origin. So what are the reasons for a central vertigo? Ramisa, can you mention some cause for a central vertigo?
Due to some cerebellar pathologies.
Okay, cerebellar, very good. One is a cerebellar pathology, infarction, hemorrhage. Then it could be because of what? Vertebrobasilar migraine. Okay. Then you have got again now the vestibular nucleus is involved in a medullary lesion. Okay. Vestibular nucleus involvement, cerebellar disorders, vertebrobasilar migraine. Well, have you heard of any vestibular epilepsy? Okay, see, there are so many other reasons where you will get what? Vertigo of central origin. So the most common are like these, and vestibular neuronitis is another scenario where you will get what? Vertigo. So vertebrobasilar migraine, and you have got, and some rare causes like you may get in multiple sclerosis. Okay, then you have got a vestibular epilepsy. It's called, okay, there's an epilepsy like that. Then migraines or vertebrobasilar infection. These are the reasons, some cause where you will get what? Vertigo of central origin. Okay. So that is how we approach to vertigo. So this patient may be having vertigo because of either a vestibular nucleus pathology or a cerebellar pathology. So those persons with vertigo again will have some ataxia and they may fall to the same side of the vestibular nucleus or the pathology. Okay, and they will have intense feeling of what spinning. Okay, so that's how we approach to vertigo. The next symptom that the person is having is unsteadiness while he is walking. This lady, okay, it is not he, she. Unsteadiness while she was attempting to walk. So for a normal walk and a stance, you should have certain integral parts in the body. So which are those areas in the nervous system which is concerned with what the normal and the walk and stance. So the main thing is what we call it as the, you should have a pyramidal system, then you should have an extrapyramidal system, then you should have a cerebellum proper, then you should have the proprioception, then you should have a proper vision, isn't it? Then you should have what else? Anything else you require? The vestibular system. Okay. So this lady was having what? Unsteadiness. So we know that these are the structures which are responsible for unsteadiness. So how do we analyze each of the symptomatology to account for her symptom? So do you think it is a pyramidal weakness that is responsible for her unsteadiness? Akhtar, do you think so?
Yes, sir.
Hmm?
Yes,
Suppose
sir.
suppose it is a pyramidal disease now. This lady might have had what could be the pattern of involvement in a pyramidal weakness? In pyramidal weakness, you will have the fine skilled movements will be more involved, and the lower limb, which group of muscles will be more involved in the lower limb? Which group?
Extensors of upper limb and flexors of lower limb.
Very good. Flexors of lower limb and extensors of upper limb. Okay, so this person will have a predilection for such group of muscle involvement. So this lady, even though she was having some difficulty, she was well able to catch hold of her chapel and she was well able to grasp the object which was given to her. Okay, that means the integrity of the pyramidal system was normal because she was able to do that. And moreover, the fine skilled movements involving the hand, catching of an object, okay, that was again what normal. So a pyramidal weakness, that means a UML. Okay, so that is highly unlikely that there is a cause for what? An unsteadiness here. So when a person is having a pyramidal weakness, the symptom that the person may have initially is what? The tripping of toes. Okay, tripping of TRIPPANG, tripping of toes, difficulty to clear the ground, slipping of chapels. Then the patient may develop what? Buckling of knees, then difficulty to catch hold of anything with the right hand. Rinsing the cloth will be defective. Like that, the symptoms will go on. So, such a symptomatology is not there here. So that means the pyramidal system may be what? Not. Now, if it is a proprioceptive abnormality in the form of what? A posterior column. What will be the problem when a person is having posterior column abnormality? Will it present with ataxia? Definitely. How? When the person is trying to close his eyes, he may be having difficulty to what? Balance. The equilibrium will be lost. So when he is trying to wash the face, especially when he is when he is washing the face or closing the eyes, in that scenarios he may tend to fall. So such a history is not there here. So it's unlikely that this person is not having. He is unlikely to have a proprioceptive abnormality. He doesn't have any abnormalities with vision also. He is able to what? See. So he was having some vertigo. So this thing, vestibular, maybe pyramidal is highly unlikely. Then the basal ganglia and all extrapyramidal, he was not, that means for the Parkinson's and other disorders, which all these require a long discussion, which is which it's not possible in a short session like this. So the basal ganglia, there is so much to discuss over here. So in this, you might be knowing the Parkinsonism gait and all, but all these scenario occur in it's a very short period. It's an acute instant. So all these will occur in what? A long-standing. Suppose it's a very long-standing pyramidal illness. What type of a gait disorder you will get? Asthma. What is a gait disorder?
Short stepping.
Short stepping gait
In
is a very in Parkinsonism. And have you heard of scissoring of gait? Scissoring of gait. Scissoring of gait is a very classical feature of a spastic gait. What is Rabisa waddling gait is a feature of which scenario? Waddling. Waddling gait. Waddling gait is a feature that is seen in proximal myopathies. Okay, what is the, do you want me to teach this more or shall we skip, move on to the topic proper? I think we move on to the topic proper because otherwise we will lag with time. Okay, so there are so many gait disorders. So among this point, all these are it's not of acute. Here it is a very short duration of what unsteadiness for while walking. So is it a cerebellar disorder? If it is a cerebellar disorder, how it presents, how the cerebellum is organizing the normal walking and how is it contributing to the normal balance and all. Actually, the cerebellum, it is mainly with, there is a terminology called as the limb and trunk kinematics. Limb and trunk kinematics and interlimb coordination. That means limb trunk kinematics and interlimb coordination. Okay, so this is what the cerebellum is doing. So if this is disturbed, and along with this equilibrium, if this is disturbed now, then the whole the person will present with ataxia. So in the cerebellar ataxia is the cerebellar symptoms are in the form of while the person is walking on a straight road, he can't walk. He won't be able to make sudden turns, and such symptomatology will progress, and this person with, suppose it is there are different types of pattern of ataxia in cerebellum. Suppose it is a Vermean lesion, Vermean, the person will have a truncal ataxia. Suppose it is a hemispheric lesion, those patients will have tendency to fall to the same side, and the cadence of movement and the appropriativeness of keeping the limbs on each and every step will be difficult, and the accuracy of what movement will be again difficult. So the Vermean lesion will usually produce what? Truncal ataxia. Okay, so based on this, the ataxia could be of what variety in this patient? Yes. So we are moving what? Pyramidal. This is highly unlikely. Okay. Now, could it be an extra pyramidal? Again, unlikely. Could it be a proprioceptive because it is a sensory ataxia? Now, vestibular, maybe. So it could be a cerebellar ataxia. So if it is a cerebellar ataxia, what is the pattern of the cerebellar ataxia? Could be of three types. What are the three types of cerebellar ataxia? It could be because of involvement of any of these three. One, it could be a Vermean. It could be a hemispheric pathology, or it could be a peduncle. Which peduncle? The inferior cerebellar peduncle. If it was a Vermean, so Mira, do you think is this patient having any involvement of Vermean? You clearly told that this person is not having any head tremor or truncal ataxia. She is not having any ataxia while she is sitting, and also, do you think it could be a Vermean?
No, sir.
Okay, so that is highly unlikely. Vermean is highly unlikely. It could be, do you think it could be a hemispheric? It could be either a hemispheric or it could be a peduncular pathology. Okay, so here we go for a central one. Okay, then okay, so here we go for a central vertigo. This unsteadiness, unsteadiness could be because of what? The unsteadiness could be because of either a hemispheric or a peduncular pathology. Okay, so is it clear? How do we approach to ataxia? So, and you want me to again repeat how do we approach to ataxia? So the ataxia could be either a sensory ataxia in the form of a what? Proprioceptive abnormalities, where the person, when he is closing his eyes, he will tend to fall. That means sensory. The next is cerebellar ataxia, where the person will tend to fall to the same side. And the truncal ataxia is characterized by the trunk. He is not able to even sit properly. He will have a head tremor, and he will fall to any sides in truncal ataxia. Whereas in a hemispheric lesion, the person will tend to the same side. Okay, then that is how we approach to what? Ataxia. Now, the third symptom is what? The sensory symptomatology. So here there are two sensory symptoms. One sensory symptom over the face and the other sensory symptom over the body. So how do we analyze such a symptomatology? Yes. So how do we approach? There are two types of sensory symptoms in neurology. One we call it as a positive sensory symptom, and the other we call it as a negative sensory symptom. So what is a positive sensory symptom? A positive sensory symptom means a person is having spontaneous sensory symptoms. That means without external stimulus, if the person is having sensory symptoms, that is called a positive. Okay, so a spontaneous sensory symptoms without external stimulus is called positive. And even with external stimulus, the person is not having any sensory input. That means he is not able to perceive the sensation. It is called negative. So the positive sensory symptoms are of two types. Which are those two types? One, it could be burning paresthesias. Okay, the next one, it could be pins and needle sensation. Okay, the pins and needle sensation is indicative of a posterior column or a large fiber pathology, whereas the burning paresthesia is indicative of a short fiber or the spinothalamic tract. Okay, so here the patient's symptoms are in the form of, you have got two symptoms. One, the person is having symptoms over the face. He says this is the right side and this is the left side. Was he having right-sided sensory symptoms over the face? Isn't it? Isn't it? So the right side of the face, he was having burning paresthesia. So that means this part of the face is supplied by the spinal tract and nucleus of trigeminal nerve. Clear. So this person might be having a spinal tract and nucleus of trigeminal nerve, which is carrying the pain and temperature sensation of the face. Okay, so the pain and temperature sensation of the face is carried via what? It is carried via the spinal tract and nucleus of trigeminal nerve. So that means now it could be what? Excuse me a moment. Okay, so the face, the face is supplied by the spinal tract and nucleus of trigeminal nerve. So that might be involved over here. Spinal tract and nucleus of the fifth. Okay, so we were discussing the sensory symptom. Either it could be positive or negative. Positive means two types: burning paresthesia and Pincenner sensation. The negative means inability to perceive the sensation. Okay, here this person was having burning paresthesia. Something is burning out the face. So that is indicative of a small fiber or the spinothalamic tract. So the face is supplied by the spinal tract and nucleus of trigeminal nucleus. So it may be an involvement of spinal tract and nucleus of trigeminal nerve. Now this person was also having what? The left side of the body was involved now in the form of again numbness and paresthesia, again which is again numbness, and in the form of burning paresthesia. So that means now the spinothalamic tract of the left side. Left sided, he is having a spinothalamic tract involved. So we will see where we could localize that. So you might be knowing how the trigeminal nucleus is arranged. So, do you want me to draw the nucleus of trigeminal nerve and explain?
Yes, sir.
Okay, so are you following now? Do you have any doubts and all?
Yes, sir.
Any
It's
doubt?
understandable. No doubt, sir.
Yes, sir. Following.
Following, okay. Any doubts from audience and all? Tanya?
Hello?
Any doubts from audience?
No, sir. For the time being, we don't have doubts. Once the case is almost fully discussed, the audience will start asking doubts.
Oh, okay, fine.
Okay, sir.
Okay,
Thank
fine.
you.
So the face, face is the face is supplied by the spinal tract and nucleus of trigeminal nerve. So we will see how the trigeminal nucleus is arranged. It is very difficult to draw and all, so pardon me for the so you presume that this part is what? This part is the midbrain, this is pons, this is medulla. So in the pons now, the mid-ponding region, you have got the dorsal motor nucleus. Okay, there is a, sorry, it's not dorsal, it's a motor nucleus of the fifth nerve. Then you have got a mesencephalic nucleus, which is extending from what? The midbrain to the level of pons. So the dorsal motor nucleus, there is a mesencephalic nucleus, which is situated in the midbrain as well as the pons. This is concerned with what? The proprioceptive impulses or the masticatory muscles. No? Proprioception from the masticatory muscle is the main function of this mesencephalic nucleus. Mesencephalic. So this is the motor nucleus. Then you have got another nucleus, that is a sensory nucleus. Okay. And that nucleus is otherwise called as the chief sensory nucleus. Chief. You have got yet another nucleus. That nucleus is the spinal tract and the nucleus of trigeminal nerve. It starts from the level of medulla, the pons, and it is extending up to the level of C3 or C4 of the spinal cord. So it's a long It's a long nucleus which is extending from the level of pons to the level of C3 or C4. So it is a long nucleus and it's called as the spinal tract as well as nucleus of the trigeminal nerve. So these are the four nucleus of trigeminal nerve. One is the mesencephalic, the motor nucleus, chief sensory, and the spinal tract and nucleus of the trigeminal nerve. Now, it's having a very peculiar innervation. Okay, so only think that this is the face. Eyes. Person is having some craniofacial dysostosis, I think so. The face is disfigured. Okay, but for your understanding, so this person. So how the pain and temperature fibers are arranged. It's having a peculiar form of innervation. So the tip of the nose and the lips. Okay, so these areas, the tip of the nose and lip, it is represented cranially. That means the upper part. Okay, and the periphery of the face, these regions, it is represented caudally. So the peripheral areas, it is represented caudally. So that means the spinal tract and nucleus is having a craniocaudal distribution of the sensory fibers, and this is otherwise called as what pattern? It is called as the onion peel or onion skin appearance. Otherwise, it is called as any other name for that?
Bella clava helmet.
So it is called as a bella clava helmet. So this is the peculiarity. Why this is very important now? Suppose there is a lesion, like an intrinsic lesion, like a syringomelia or syringobulbia. If it is coming to the bulb, it is called syringobulbia, or a syringomelia if it is in the cord. So in that scenario, the fibers, in an intramedullary lesion and all, the peripheral facial fibers will be involved if it is syringomelia, and syringobulbia, usually the upper part. So there is the peculiarity of the sensory innervation of the trigeminal nucleus. You should know, and you should learn this. Otherwise, it will be very difficult for you. Sometimes you may check sensation somewhere, periphery and all. So if it is a medullary lesion, the sensations will be somewhere over here. Okay, so depending on the craniocaudal distribution, the sensory innervation varies. Is it clear?
Yes, sir.
Okay, so the next symptom is what we call it as dysarthria. Okay, so how do we approach to such a symptomatology? So this person was having dysarthria and dysphagia. So could it be, it was a speech, do you think it could be an aphasia?
No, sir.
Why no?
He was
Patient
able to speak properly and he was able to comprehend what was told to him.
Okay, so aphasia is a language disorder, whereas now dysarthria means now it is a articulatory abnormality. So the dysarthria could be of different patterns. In undergraduate level, it's now I will give a very simple description, but so for your idea, this dysarthria could be either it could be a upper motor neuron type or the pseudo bulbar or upper motor neuron type. Okay, upper motor neuron. Then it could be an element type. Then it could be the extrapyramidal. Then cerebellar dysarthrias are there. Okay, so these are the different types of dysarthria. So articulatory abnormality. So what is called as an upper motor neuron dysarthria or human dysarthria? The characteristic features in this scenario are this person will be usually bilateral upper motor neuron disorders, usually present with what? And human type of dysarthria. In that, the person will have emotional incontinence, and the person will be having a difficulty in swallowing and all, and along with that the person will have dysarthria. If you ask the person will have a spastic tongue. Here the main feature is the person will have a spastic tongue. Tongue will be protruded as such and it will be pointed, and it's a spastic tongue. And if you ask the person to say what British Constitution, he may say like brush constitution. He may not be able to pronounce it properly. So you ask him to say British Constitution. If it is like that, a British Constitution, that means he is having. So what is the most common cause of dysarthria, Biran?
Absence of teeth.
Oh, very good. Fine. Absence. So before checking that, you should assess what the teeth and all. So elderly individuals, maybe even if you ask British Constitution and all, they might not be knowing any English. So be cautious in evaluating such patients. So it's spastic tongue and emotional incontinence. Okay, that goes for a pseudobulbar dysarthria. Now you have got extrapyramidal means that occurs in a base. Suppose it is a Korean and all, you will have a jerky speech, and then you can learn other details and all. But in this, I will more focus on the cerebellar and element dysarthria. So the cerebellar dysarthria means here the person will scan each and every word that you say, and there may be some undue stress for some of these words. Suppose you ask them to say Tiruvananthapuram, what they may say like Tiruvananthapuram. That means they will scan each and every word in that Tiruvananthapuram. Suppose you ask him to say articulary, he may say like articulary. That means undue stress as well as scanning of each of the words will be there. So that's how a cerebellar dysarthric speech will be. Either it may be a staccato or it could be what we call it as a, that is other name for the cerebellar dysarthrias. You may have staccato or scanning speech. So staccato means there is undue what stress also given to each and every word. Okay. Then you have got element dysarthria. Element dysarthria, you have got three types of element dysarthria. One we call it as the labial dysarthria. The other is called as lingual dysarthria. Then you have got the guttural dysarthria. Okay, so the labial dysarthria occurs when the person is having abnormalities of element type of facial palsy. Okay, in that scenario, the person may not be able to say certain words like what? Ma, pa, ma, pa. Okay, so the words like ma, pa. In music, the swarasthanas ma, pa will not be the for facial palsy. Do you remember any person who has made a raga without ma, pa when he developed a facial palsy? Hmm? So go and find out. There is a person who developed a raga called Diroshta, where there is no ma, pa. Okay, so suppose you develop facial palsy, will you develop ragas or you will what? You will go and treat it? Hmm? Okay, so that's how our ancestors approached to illnesses. They knew that they may recover. I don't know what they might have thought. So the lingual, you have got a lingual dysarthria where it is because of the abnormalities of hypoglossal. Okay, so in that scenario, the person will have abnormalities in speaking what? La ta, little. He may not be able to say la ta. So little, la. Okay, and guttural means no. L T. Okay. So here guttural it is called ka, ga, nga. Okay. So the gutturals ka, gha, gha. Okay. Ka, gha, gha, nga. Okay. Gutturals. So when the person is having high guttural dysarthria, the hypernasals. Okay. So guttural dysarthria occurs because of a vagus involvement. Okay, so it is a guttural dysarthria when the person is having 9th and 10th palsy, you may have a guttural dysarthria. So usually bilateral lesions usually produces, or unilateral also will produce, but it is more pronounced. Okay, so this is how we approach to dysarthria. So this person was not having any forms of scanning or anything for the speech, but she was not able to say ka, ga, na. That means it may be a guttural dysarthria. So she was having guttural dysarthria. That means it may be a 9th or 10th involvement here. Now, and she was also having difficulty in swallowing. So the difficulty of swallowing again because of what? Difficulty of swallowing occurs because of 9th and 10th involvement. So that goes hand in hand. The next symptom that they realized was what? Drooping of eyelids, which we call it as ptosis. So, Biran, do you think it was it a proper complete ptosis or a partial one?
Partial ptosis.
Okay, so when you are mentioned regarding drooping of eyelids, you should also mention regarding whether it is partial, whether it is unilateral, whether it is fatigable ptosis. Okay, suppose it is fatigable ptosis, what you will consider? Myasthenia gravis. Okay, suppose it is no complete ptosis, it indicates it's a third nerve palsy. So the ptosis means usually the 1/3 of the palpebral fissure is what? Covered by the upper lid. So when it is more than that, no, you call it as ptosis. So a ptosis occurs either because of a Muller's muscle palsy of sympathetic origin. So was this patient having a sympathetic trunk involvement in the form of what? Ptosis, meiosis, to account for what? That we require what? Clinical examination to look for meiosis and what? Anhydrosis and in ophthalmos to account for what? Horner syndrome. So we presume that it may be a sympathetic trunk involvement and it was a unilateral partial ptosis. So analyzing this symptomatology, here the vertigo goes for a vestibular nucleus, okay, which is called as the 8th vestibular nucleus, or it could be what? A cerebellum. Okay, the unsteadiness could be because of cerebellar hemispheric pathology, or it could be a peduncular pathology. Okay, then the sensory symptoms of the face is because of the spinal tract and nucleus of the trigeminal nerve, 5th. This is because of 9th and 10th. The drooping of eyelids is because of sympathetic trunk. So you got what? So many structures are involved in this patient. So where you want to keep all these? So these are the vertical localization. That means you have found out that these structures are involved in this patient. Now you should draw an area like this in a horizontal level, and you should say that this is at this level that this person is having a disease. So how do you find it out? So how do you find out that you are smelling that it's you are smelling that there's a biryani is being made? So how do you make out that it's a chicken biryani as well?
We have to find that cracks chicken in it.
Okay, you will find out chicken. Suppose no, your brother ate all chicken in it, and the biryani is only there. So how do you find out that it is still chicken biryani? You will get the flavor of chicken, isn't it? You will get
Yes.
the flavor of chicken will be there. All other ingredients will be same for all other biryanis, egg biryani, mutton biryani, or whatever biryani you eat, or veg biryani. So the flavor of the masala and all will be the same. But no, the crux will be the sometimes no, you may get what egg and all. So sometimes it will be only chicken. So we have to what find out the crux in a clinical. So what you think here the crux has? So here now you have got, so how do we identify the crux? So you know that the sympathetic trunk is a trunk going like this. Spinothalamic tract is a tract again going like this. Spinal tract and nucleus of trigeminal nerve starts from the pons and extending like this. Okay, but you have got what the 9th and 10th is staying over the one area. Is it like that? Is it like that?
No, sir.
No, or is it spread over a wide area or a small area?
Small area.
Very small area. See, it's how many, see, up to what standard of students will go for LP school?
4th standard. Up to 4. 3 and 4.
Okay, so 3 and 4 goes for what? The midbrain. Okay, the 5th, 6th, 7th students will go for what? Pons. The 8th to 12th up to +2 will go to what? Medulla. Is it clear? So, the medullary lesions, you will get what? 8, 9, 10, 11 and 12. So here you are having what all cranial nerve involvement? 8th is involved. Is it like that? Yes. Vestibular nucleus? Okay. 9th and 10th, is it involved? Yes, definitely. So, do you want to localize this to pons only because of the spinal tract and nucleus is involved? No, because it is present from pons up to the level of cervical cord. No, so you can't. What will presence of turmeric in a curry? Can you make it as fish curry? No. So that may be an ingredient in so many other curries. Like that, the spinal tract and nucleus of trigeminal nerve is extending from pons to the level of cervical cord. So that doesn't mean you need to localize based on that, but you have to localize based on this crux. So you are localizing the disease to which area? Horizontal localization to medulla. Is it like that? So this person may be having a medullary pathology. So we are going to see how this medulla, the structure of medulla, where these structures are localized. Is it clear? Are you following?
Yes, sir. Follow.
Yes, sir.
Okay, so tell me, which are the paramedian nucleus? There are only two paramedian nucleus. So which are those two paramedian nucleus? All other cranial nuclei are lateral, and no, only two nuclei which are paramedian. Which are those?
11 and 12.
11 and
11. No, it is 12 and third. Okay, it is 12 and third is what paramedian. Third is localized in the periaqueductal grammata. Okay, third and 12th, that is hypoglossal. Okay, so now if you want, you can draw along with me, and you can. I will mark the structures in the last. Okay, I will mark from now itself. So this is. I will draw the nuclei. 8. This is third. Sorry, 8th nucleus ambiguous, nucleus tractus solitarius, spinal tract and nucleus of trigeminal, spinothalamic tract. So I will mark all nuclei in yellow. So this is one nucleus. This is another nucleus. Okay. So this is vestibular nucleus. This is dorsal motor nucleus of vagus. This is nucleus ambiguous. That is the motor nucleus of again 9th and 10th. This is the spinal tract and nucleus of trigeminal. Okay. So these are the nuclei. Now we have got, this is the spinothalamic tract. Okay, so spinothalamic tract. So this is the sympathetic trunk. Here you will have an inferior olive, So you have got one more nuclei which I forgot. What is that nuclei? Nucleus tractus solitarius. So this is nucleus tractus solitarius. Okay. And now I forgot to mark this structure. This structure is otherwise called as the
Inferior cerebellar peduncle.
Inferior cerebellar peduncle, or otherwise called rustiform body. Inferior cerebellar peduncle. Shall I mark the small forms now, like ICP, inferior cerebellar peduncle, otherwise called the rustiform body? Okay, so the whole portion goes for the lateral medulla. Okay, so this whole portion is going for the lateral part of medulla. On the medial side, you have got few more structures. This is the hypoglossal, and the hypoglossal now will go like this. You have got another structure here and another structure over here, and that structure is to sensory I have marked in what? Red. I have marked all sensory in red. Okay, all cranial nuclei in yellow. And now I am going to mark one more, that is the pyramidal tract. I think now I have drawn each and every aspect of this thing which is required in an undergraduate level. So I hope it is clear. Now this is the inferior cerebellum. Am I slow or should I go fast? No? This is the inferior cerebellar peduncle. Okay. This is the vestibular nucleus. Now this is the motor nucleus of vagus. Nucleus ambiguous is here, which is concerned with what? The motor functioning of the 9th and 10th. So nucleus ambiguous, NA means nucleus ambiguous, which is concerned with the motor functioning of the 9th and 10th. And this is what we call it as all sensory arrow marked in red. So this is the spinal nucleus and the tract of the trigeminal nerve, which is extending from the level of pons to the level of cervical cord. Now you have got another long tract, that is a spinothalamic tract over here, and you have got a sympathetic trunk over here. Okay, now, so all these structures belong to the lateral part of medulla. Now, this structures, there is the hypoglossal, the medial lemniscus. Medial lemniscus, that means the posterior column in the lower part of the midbrain will cross to the opposite side. Okay, and it will come medially. And it goes as medial lemniscus to synapse in the ventral posterolateral nucleus of thalamus to convey the posterior column sensations or the proprioceptive impulses. Okay, so this is what I was telling regarding now the sensory ataxia, the posterior column, and this is the pyramidal tract. So to your knowledge, most of the time the pyramidal tract is always what? Median. It is located medially, and most of the cranial nerve nuclei are located laterally. The exception is 3rd and 12th. Okay, so this person was having an involvement of what? The 8th nerve nucleus, the cerebellar peduncle, and the person was having involvement of the spinothalamic tract. Why? Because this person was having a pain and temperature was lost on the which side? On the sorry, I drew it on the opposite side. Actually, this person was having symptoms on the right side. So you have to mark this as what right and this as left. So all the symptoms of this person were on the right side. Okay. So if the whole structures on the right side. Okay. So this inferior cerebellar here, no? If you mark this as right and left, only the right side of this person is what involved in this patient. In this person, the right side of the, because the person had a right-sided ataxia. Okay. And when I drew, I drew all structures on left side. Okay. If you want me to draw again on the right side, Tanya, is it, are you getting confused or can you follow now?
Yes, sir, it is clear. We can follow this picture.
Okay, so it's all structures on the right side of this patient is involved. I just drew all structures on left side, but when we are concerned regarding this patient, now this patient's right side of the lateral medulla is involved because this patient had an unsteadiness towards the right side. The right side of the face was involved and left side of the body was involved. So the spinothalamic tract on the left side. If it is involved on the right side, the person will have a contralateral sensory loss. Do you want me to explain that? Because when the pain and temperature fiber, it comes like this. It will cross to the opposite side on the site of entry or one or two segments up that level. So on the entry itself, the fiber comes like this and it will cross to the opposite side and then it will ascend up as spinothalamic tract. Okay, so when a person is having involvement of this spinothalamic tract, the person will have involvement on the opposite side. So when this spinothalamic tract is involved, the person will have involvement on the opposite side. Okay, hope it is clear. So the localization of this person's disease is to the medulla, and that to the right lateral medulla. So we are localizing the disease to right lateral medullary syndrome. So it is a right lateral medullary syndrome. Okay, so we have reached at what level from history? From history, we could realize that this person is having a cerebrovascular accident in the form of an ataxic syndrome involving the right lateral medulla. Now, what is the question? Now the question is, what is the pathology? What could be the etiology in a 34-year-old lady? Is it like that? Yes. So I hope this picture is clear. Then if it is clear, and if do you want me to explain what all phenomena will happen on the one side and the opposite side, and do you want me to write that and all? Then I will write on the right side of this. Okay, so I will write down the salient features, how to diagnose. Okay, okay. So let me ask you something first. Okay, Ranisha, can you tell me what is the? You have got so many structures are involved over here. So do you want me to tell that no, with only these two things, no, I can make a diagnosis of lateral medullary syndrome? Or what is the classical triad of lateral medullary syndrome?
So there will be ataxia.
Okay, be specific. Ipsilateral ataxia.
Ipsilateral ataxia will be there, and we can suspect this cranial involvement. That is 9 and 10 is there. Then also spinothalamic tract involvement is there in the form of burning paresthesia.
That is very good. So, constellation of these three findings in the form of what? Ipsilateral ataxia, contralateral hyperalgesia, that means loss of pain and temperature, and cranial involvement, that is 9th and 10th, is the classical triad of lateral medullary syndrome according to Podbrasis. So, now, Biran, can you point out what is the most common finding apart from this that a person with lateral medullary syndrome will have?
Dysphagia.
There is no, the triad is there now. Along with that triad, you will have one more common accompaniment.
So UMN facial weakness.
It may have that. I will ask another question. Okay.
Sympathetic involvement, sir.
Very good, Asmil. That is the sympathetic nervous system involvement is the most common involvement which you will get in a lateral medullary syndrome apart from this triad. Okay, so Ramisa was saying, so can you have, can you believe, Tanvir, that a person will have a UMN facial palsy in a scenario like a lateral medullary syndrome?
Usually, the seventh nerve nuclear tract arteries will be involved.
Okay, that I agreed. My question is different now. Could you get a UMN type of facial palsy in a medullary lesion?
Yes, sir. Because some facial fibers descend down into the medulla as loop, Dejering's loop is called, and it turns upward.
Yes, actually, that's the answer. That means no, so some fibers, no, you always know that there are certain. Suppose you are asked to say that you should not go to that side, no. What will be your aim? You will definitely go to that side. Like that, no, the seventh nucleus, the fibers, no, once they reach as corticonuclear fibers from the cortex, no, these fibers, now all of the fibers, there will be a signal that you descend over here. This is your place. Your home has reached. You just descend over here over the seventh nucleus. So what some fibers will think that why now I should live over here. What is there over the medulla? I would like to go there and see. So some fibers will descend down to the level of medulla, but will it get a landing zone? Suppose a plane is going to Calicut, and now it is landing over. Is it possible to land over Trivandrum without any information? No, it will not get a landing zone. So, like that, no, these fibers will not get a landing zone, and it will again come back to their parent seventh nerve nucleus. So, some descending fibers, and these fibers are called degerent loop. Okay, so that's how you may get even a facial palsy in the case of lateral medullary syndrome. So, now I would like to again mention what are findings you will get in a case of lateral medullary syndrome. Now, do you want me to keep this picture over here? Okay, so I will try. Suppose it is a right lateral medullary syndrome. Right lateral medullary syndrome. On the same side, suppose here it is involved. What are findings you will get on the right side? The triad you can write. What will be the ipsilateral ataxia? You know why that ataxia occurs. Ipsilateral ataxia. And on the same side, you will have 9th and 10th palsy. Then you will have, on the same side, you will have sympathetic trunk involvement in the form of what? Horner. Okay, then what else you will have? You will have nucleus tractus solitarius involvement. Then you will have the ipsilateral sensory abnormalities over the face, ipsilateral face. Okay, so these are the findings that you will get over the same side. Ipsilateral ataxia, the difficulty in swallowing because of 9-10 palsy and the dysarthria, Horner syndrome. You will have the nucleus tractus solitarius involvement, and you will have the spinal tract and nucleus of trigeminal nerves involved. So in that scenario, you will get what? You will get a ipsilateral pain and temperature will be lost on the same side. And on the left side, you will get what? You will get loss of pain and temperature because of the spinothalamic tract involvement. So I hope it is clear. So if you are getting a patient like this with these features, your diagnosis is none other than what? Right lateral medullary syndrome. Is it clear? Yes. Now this is the classical lateral medullary, and you will get so many other findings other than this. As just we mentioned, no, human facial palsy. You may get sometimes some facial fibers will land over here and it will go up. So you may even get a human. Suppose you are getting an element facial palsy, you should think that the lesion is extending to the level of what? Pons. So a pondomedullary disorder you have to take off. So shall I? Do you want me to teach more on? Is it your time? It is. Are you getting bored or anything like that? Just inform me. So, do you want me to continue more?
So we haven't discussed on the pathology and etiology.
Okay. So we will discuss. Okay. So now we move on to the pathology. So for this now, we should have an idea of what since we told it is a cerebrovascular, disease. You should know what is the vascular supply of this region. Is it like that? Yes. So can anyone say, or I will? Okay, I will because there is a lack of time. I will just brush up how these vessels are, the supply of the vessels in medulla. Suppose this is the medulla. You have got the vertebral arteries. Okay, so the vertebral artery, and now you have got two vertebral arteries which will join to form what we call it as the basilar artery. And this basilar artery divides to form two posterior cerebral arteries. Is it clear? Yes. So this vertebral artery will set up lot of branches to the medulla. So this vertebral artery provides set of arteries which will supply over the medial part of the medulla, small arteries. So these arteries are called as paramedian. Okay, so paramedian arteries. You have got another set of arteries which are called as these are little bit what short, so you call it as short circumferential. So short circumferential arteries. And you have got a long circumferential here, which is that long circumferential is called as the pike, posterior inferior cerebellar artery. So that artery is the artery of what? The restiform body or inferior cerebellar peduncle. Like that, the vertebral artery gives another branch called as apart from the 1 centimeter, not just apart from the origin, it will give another artery that is a long circumferential, that is pica. It again provides short circumferential and paramedian. And before the exit, it will give another long circumferential that is called as the scar or the superior cerebellar artery. So this is the main arterial system of the posterior circulation. So paramedian, short circumferential and long circumferential. So this pica is mainly concerned with supplying the lower portion of the cerebellar hemisphere, inferior cerebellar peduncle, and the lateral portion of the medulla. Okay, the ICA is concerned with supplying the lateral part of the middle of the cerebellar hemisphere portion of vermis, as well as the lateral portion of the pondomedullary area in the inferior part. The paramedian vessels will supply the medial part, and the short circumferential will supply the medial part. And to your knowledge, this paramedian infarctions are always lacunar. The paramedian vessels will produce lacunar infarct, usually very small infarcts. Okay, so this medulla is having another set of arteries. They are the anterior and posterior spinal arteries. You have got anterior and posterior spinal arteries. You have got the vertebral artery, that is the main supply. You have got pica. Okay, so and you have got superior, middle, and inferior lateral medullary arteries, otherwise the short circumferentials. Okay, so these are the main arterial supply of medulla. So here it will be what? An ICA, because this patient is having also involvement of what? Cerebellum, the peduncle, and the lateral medulla. So our patient might be having a ICA involvement. Okay, so this is the artery that is involved. Now, what could be the pathology in that artery? In that artery, what could be the pathology? For that, shall I wipe out this thing? Artery and all?
Yes, sir.
Okay, sir.
Okay, so now we have got another area and we are going to analyze. So you think that there is a thrombus over here, there is an artery over here, and now, so what is the difference between now a thrombotic event as well as an embolic event? That's what I am going to discuss now. Thrombotic, there is three pathologies are there. It could be a thrombotic, it could be an embolic, or it could be a hemorrhage. Okay, suppose it is a thrombotic one. Thrombus means there is the cholesterol-rich thrombus is there here in the artery, and now this thrombus will get either ulcerated, calcified, hemorrhage, or infection. So all these will invite the platelet and the fibrin, and the clot will be formed like this, which will jeopardize the blood flow to the distal area. So what happens? So once it is happening like this, so the person will take, the thrombotic event, it will occlude over a period of what? There will be, you will get a definite time. So all these phenomena will take, if it is a thrombotic one, the person will have a onset of sudden, it will be of a sudden onset, and the melodrama will occur over a period of hours. Suppose it is an embolic one, Suppose an embolism from the heart or any great vessel, suppose aorta or from the heart, suppose an embolus comes over here. The embolus, if it is blocking an artery like this, the whole of the artery is blocked at once. So all of the symptom will occur at that point of time itself. The maximum weakness will be on the first presentation itself. The maximum weakness and involvement will be in that point of insult itself. So abrupt or rapidity of onset and a predisposing condition like what a atrial fibrillation or a thromboembolic phenomena, if it is the thing that it could be an embolic occlusion. Suppose now the symptom is occurring over a period of hours and it is progressing, and I told here now the symptoms are over a period of 2 to 3 days. That means the stroke in evolution. For a posterior circulatory stroke, the whole melodrama will get completed over hours and it may even extend up to 3 days. That is what we call it a stroke in evolution. So in posterior circulation, it may take even 72 hours, whereas in anterior it is 24 hours, according to Paul Bryces. Okay, so here this thrombotic occlusion, and it is very difficult clinically to say whether it is thrombotic or embolic. But if you are having a predisposing condition like a atrial fibrillation, and most of the time it may be an embolic. In a hemorrhage, it's easy because the hemorrhage means the blood will flow from what from the lateral part. Suppose there is a hemorrhage over here, it has got no boundaries that I should restrict our what? The lateral part. It may even extend to what? The medial part. So it may not show the strict arterial territory and all. It may flow from the left side to what? Even the, so it may occur as a lateral or medial medullary combination you may get. So it will be associated with severe headache, nausea, vomiting, and all features of increased ICT. So here you presume that this person might be having either a thrombotic occlusion. Do you have any other points to say, any other pathology in this lady? Kamisa?
Sir, our neck pain history.
Yes, she was saying the history of severe intense neck pain, and neck pain can be a common feature of even a neck pain can occur in a vertebral stroke itself. Okay, but an intense neck pain usually indicates vertebral dissection. Suppose there is an intense neck pain, vertebral dissection is a most, or spinal arachnoid hemorrhage, or vertebral dissection is a common finding if you are having such an intense headache. Okay, why this the year began? Do you find it out any abnormality in the history? Like this lady was doing an excessive work, and after that she developed. Is there any point to suggest any form of pathology?
She was doing exertional work.
Okay, so what?
The blood demand is increased, and
Okay.
I don't know sure.
Field phenomena can occur.
Yes. Yes. Suppose the right side of this lady's vertebral arteries having some congenital stenosis or some occlusion, and the collateral is not adequate. The collateral, there will be always collaterals, Suppose, so the subclavian artery will steal the blood from what? Vertebral, when the person is doing an excessive work with the right arm. So the person is prone for what? A vertebral occlusion and stroke. Okay, so such a history is really nice to take a history on what excessive work. Suppose a teacher who is continuously writing on the blackboard suddenly developing this thing. Again, is another phenomena which can happen with subclavian steel and all. Okay, so now we have got another discussion to do on what the how this lady, she's a 34-year-old lady, and what could be the cause in a 34-year-old lady. So the etiology discussion is in another area, but now our area of interest was how to analyze a clinical diagnosis based on the symptomatology analysis. So this patient's symptoms were pertaining to neurology, and we analyzed what the symptoms one by one, like how do we approach to vertigo, how do we approach to unsteadiness while walking, how do we approach to the sensory symptoms in this patient, how do we approach to the dysphagia and dysarthria, and grouping of eyelids. So based on that, after analyzing the symptomatology, we got certain anatomical structures which are responsible for the above mentioned symptomatology. And consolidating these anatomical structures, we could identify the crux structure in this, like what the cranial nerve, that is 9th and 10th, and that is located in the medulla. So we presume that this person could be having a medullary disorder, and even that it's a lateral medullary syndrome. So it's a lateral medullary, right lateral medullary area is involved. So the anatomical localization is going to the right lateral medulla. Now, so this person's the topography was an ataxia, the type of the disease was a cerebrovascular accident manifesting in the forms of after history. You have a complete diagnosis with you, like this person, this lady, a 34-year-old lady, was having a cerebrovascular accident in the form of an ataxic syndrome involving the right lateral medulla because of a thrombotic occlusion or a vertebral dissection. Okay, it could be a right lateral medulla infarct, or it could be a thrombotic occlusion, or it could be even a dissection. And the predisposing factors, the etiology, we should find out. For that, we require the past medical history, whether she was having any valvular heart disease, whether she was having any thrombotic conditions that she is having, like any other arthritis, or whether she was having any connective tissue disorder, was she taking any drugs, any propagulant conditions, or any congenital abnormalities with the protein C deficiency, and the phosphorylated antibody syndrome. And so many scenarios are responsible for a young stroke, and even it could be a cardio emboli, or it could be an aorta emboli, and it could be even so many scenarios we have to discuss on that. So for an undergraduate, you should be able to identify the anatomical localization based on the symptomatology. So now you have got a clear-cut diagnosis with you. That means a well-funded history is enough for making a clinical diagnosis. Plus, you should do some clinical examination. Sometimes, suppose you are getting a human facial pulse on clinical examination, that adds on to the diagnosis of what an aberrant loop of facial nerve is there. Suppose you are having a ipsilateral hemiplegia, suppose the plantar is extensor on that side, you have got another diagnosis in the form of what, Tanya? Any idea? Suppose this person is having an ipsilateral hemiplegia. It's called as the submedullary disorder of the Opalski syndrome. Okay, so like that, we have a lot more to discuss, which require another sessions and all. So I think now the time is now 10:30. So we started by 8:30. So past 2 hours. So all of you might be what. I don't know whether you could follow these things. So if you have any doubts and all, you can ask.
Just a comment section.
Hello, sir. So we have few doubts from the audience part in the comment section.
Okay. Can you say the doubts, or you can post?
Check the comment chat box.
Okay, I'll check. Okay, so only 2 doubts. Okay, so the doubts are: can we get ipsilateral dorsal column involvement in lateral vertebral syndrome. Okay, you will definitely will get. How now? I will present that picture again and I will tell you. So, can you see that? See, I told you the posterior column is located over here. Okay, so when the posterior column is located here, I think Tiny, you can see that, no?
Yes, sir, it's visible.
Okay, so suppose you see the lower part of the medulla, this posterior column is situated in the posterior part. Okay, when it is coming to the upper part of medulla, this will cross to the opposite side. Okay, and it will become medial lemniscus. So if you are getting a lateral medullary syndrome in the lower part, you will get posterior column involvement in the same side. That's possible. The next question is, what is the least degenerative slope seen in all individuals? It's not always, it's a very rare. Any other doubt from the audience? There are a lot more to discuss. If you have any doubts, you can ask. Tabisa, Tanya, you are not asking any doubts. Why? Saurabh, why you are not asking any doubts? You understood? Now is it very easy to go to the ward and take a case and diagnose lateral medullary syndrome? Okay, how to differentiate between LMN and UMN facial palsy? Okay, that's not a topic to be discussed over here. Okay, still I will explain. It's very easy to distinguish between LMN and UMN facial palsy. So actually, I will say, okay. So the LMN facial palsy means the whole one half of the face is involved. The human facial palsy means it's only the lower part of the face is involved. Suppose I am having a human facial palsy, my face will be, see, there will be a facial deviation, and the angle of face will be deviated to one side. Suppose my upper part of the face is completely spared. I am well able to close my eyelid like this, and there is only facial deviation that indicates it's a human facial palsy. Suppose I am having the lower part of the face as well as I am not able to close my eyelids properly. And in that scenario, I will get again what a Bell's phenomenon. Okay, so on attempting, see when we close the eyelid, both the globe will go up. So inability to close the both eyelids because orbicular and oculi will also be involved. So in that scenario, you will get the upper part as well as the lower part. So there are certain subtle signs to identify that there is an element facial palsy. See, you will have a Bell's sign always. Okay. Apart from that, you may have some. Suppose you look at a person with element facial palsy. You look at the blink rate. See, blink rate. See, one eye, I can't do that, no? Okay, suppose now I blink only with the right eye and the left eye is not blinking as properly. That again, number of blink rate is reduced. Okay, that's again another finding to say that it could be a what element facial palsy. So one half of the face completely involved with you may get what the taste sensation may be gone, you may even get a hyperacusis, okay, and the corneal and conjunctival reflex may be absent in all this. So that accounts for an element. Whereas in a human, only you will get what? A facial deviation. Okay. Any other doubt? The structures in pyramidal and external differentiation between. This doubt is if I should take two classes that the explaining structures in pyramidal and extrapyramidal system. Okay, so that will take one session and we will discuss how pyramidal, extrapyramidal and all. Any other doubts? Shall I ask some questions?
Okay, sir.
Okay, so do you want to learn more on lateral medullary? What is called, what is the other name for lateral medullary? That is Wallenberg.
Wallenberg syndrome.
What is Ondine's curse, Biran? What is Ondine? And what is Ondine's curse? See, Ondine's curse. Now, suppose the respiratory center is involved. This person will forget that he is what? Only if he is conscious and if he is voluntarily taking his respiration, he will be able to survive. He can't sleep. It was a curse to Ondine. Okay, so Ondine's curse is called that you can get in lateral medullary syndrome. And there are so many difficulties which you may get in lateral medullary, which now we will discuss later. If you have got any other doubts or anything, we will discuss or we will wind up the session.
Sir, is degerens loop involved in all individuals, or is it a rare entity in some patients?
It's a very rare entity, no? It's a rare entity. Hematoma right cerebellar with ischemic changes. What is the doubt?
So we have one more doubt in the chat box.
Okay.
Question is, sir, can a patient present with hematoma in right cerebellar hemisphere with ischemic changes in medulla and internal capsule with the same features?
I didn't get that question actually. When a patient presents with hematoma in right cerebellar hemisphere, okay, one localization in right cerebellar hemisphere with ischemic changes means with ischemic changes in medulla also. So one, there is a bleed and there is an infarct in medulla, and in see, can you ask that candidate what she actually meant me to discuss on? I didn't
Yes.
get that.
Hello, Ramisa. I think you can unmute and ask directly.
Sir, actually, this is a case.
Okay.
So the patient was presenting with vertigo, and he had some episodes of vomiting and was unconscious while he was taken to the casualty.
Okay.
And examination, his power was normal, and all other sensations and all things was normal.
Okay.
And this is what I written was the CT finding.
Okay.
It was given a right hematoma in the right cerebellar hemisphere and some hypodensities in the medulla and this anterior limb of the internal capsule.
That can happen. No? Suppose a person is having an old infarct in internal capsule and medulla, now presenting with a bleed in what? Cerebellar hemisphere. That you can have.
Okay. So then also he's not presenting with any symptoms of medulla.
Okay.
And
You want to know because that means now medullary infarcts and all may be old, might have recovered, maybe a paramedian lesion. So not all CT findings may not represent what clinical findings because there may be extensive collaterals. Okay.
Okay, sir.
Okay. So anything else, audience or no one is having any doubt? Why? Because all understood or none understood.
All understood.
All understood. Okay. So thank you for a nice listening.
Sir?
Yeah. Any more doubts?
No, sir. All doubts have been included in the chat box. So I think we can wind up the session now.
Okay.
Okay, sir. Okay. So with that, we have come to the end of the session 1 of the lecture series, which was conducted as a part of the DAMS MedMeet conference by Government Medical College Calicut. I hope all the audience have enjoyed the session, and more than enjoyment, I hope all of you have gained some knowledge and have got a clear idea about the case on lateral medullary syndrome. So, in this late hour, I would like to thank Dr. Danish E, Assistant Professor from the Department of Medicine, Government Medical College, Kozhikode, for providing us with such a wonderful session. Thank you so much, sir. Thank you for availing almost 2 hours of your time to us. Thank you so much, sir.
Actually, no, yeah, continue.
Also, I would like to thank all our audience who had been watching the session live in the YouTube. So thank you, sir, and thank you all.
Actually, no, I have been having this hospital hours so many days, and I have not been taking a single class for the past 2 or 3 months. 2 months, I think so. And I again really enjoyed taking class to you after so many days, and it has been an immense pleasure from my side to take a session to you. I could give you some idea. If you have got any doubts, no, you can ask me through WhatsApp or mail. I will provide you any information which I do have. And thank you for your nice cooperation, all my dear students. Tanya, Ramisa, Akhtar, Asmil, and Biran Saurav for conducting this, and the DAMs for providing a chance, and the college union, because it has been a very nice event on the part of union to conduct such a educational meet, and to collaborate all students in all over India, and to share the knowledge from this college, and to conduct such a session is really wonderful, and to be a part of this, again, I am so esteemed, and I extend my thanks to the whole team, and thank you all, and have a good night, and stay safe, and be cheerful. Bye.
Okay, sir. Once again, thank you, sir, and thank you all. Good night. With that, we come to the end.